We're continuing on here. Well, we're going to finish up on here at the end of the quarter. This last week is to talk about psychological treatment. And today I kind of want to do this same thing I've been doing kind of all along, these whirlwind tours through a huge body of material to just kind of give you some familiarity with the various types of approaches to treating psychological disorders. And we're going to talk about sort of every major kind here: biomedical approach, psychoanalytic, humanistic, cognitive, behavioral approach, and kind of walk through all those, and I'll tell you a little bit more about that here in a minute. So again, my reminders: so if you're going to do these research reports, they're due in class on Thursday, and hand them in physically on paper, right, in here at the end of class. So bring it with you. We won't take any late papers. SONA credit, again, which I think is a better way to do this, much easier way to get your extra credit points. So there's lots of studies up, and again, you can do that all the way through the end of this week. So go ahead and get your extra credit points. Course evaluations, make sure you do those for this class. For all the other classes, it's really good. You should have those, get those emails. The final exam, just to start this process of alerting you to this, again, it's a week from Thursday at 8 a.m. in the morning, so bright and early. Again, in here, there'll be an overflow room. So if that's your deal, come and do it. Go to that one, you'll get an email. 64 questions, exactly the same as the other one. It's not comprehensive. It's just based on the material in class since the last exam. And that, so all the stuff about psychological treatment, chapter 16, 17, and the 3 Norton readers. Bring all your stuff. There'll be a study guide posted by the end of the week. Right, all this week, in discussion sections, they'll be going over material, and so go to those, do what you need to do better on the exams. Go ahead.
8 a.m. to 10 p.m., huh?
Is that what it says? No. It'll just feel that way. So you had that look on your face like I did something where I could tell without looking back that there must have been some kind of mistake on. Yes, I switch these things fast. So 8 a.m. to 10 a.m. Okay. So when I talk about, what I like to talk about in psychotherapy and psychological disorders, again, it's kind of how we think about those things and how we think about psychological disorders differently than we think about physical disorders, right? There's this real desire to think about them as if they're physical kinds of conditions, right? We want to treat them that way, but they're just not that, right? They're this more complicated thing, and some of these, cartoons sort of illustrate, the silliness of the way we think about, the way we act. If we really think about psychological disorders as kind of real conditions, they're real, they're different from physical ones, right? But they're real things. And there's this kind of funny, right, complication and blurring of the way we think about psychological disorders, right? And so it's always been hard to think about treating them. Physical disorders, we kind of know how to treat them, right? We know, oh, gee, you've got some injury, you've got some illness, there's some biological basis for that, and we're going to try to fix those sorts of things. But we know from research, right, is that these psychological disorders just don't have quite such a simple etiology, right? So they have some biological causes underlying them very often, right? But there's almost always some kind of psychosocial issue, right? Some life experience that brings these things to the surface, and it's a complicated set of causations that people talk about, right? But one of the sort of overarching notions that I want to sort of use to organize today, I guess, is that it's how you, because we don't know and people differ on what they think causes psychological disorders, they differ in a very obvious way in how they think psychological disorders should be treated, right? And what you think is the cause depends, or how you want to treat it really depends on what you think the cause is, right? So if you really think that the cause of psychological disorders is demonic possession, right, then maybe it makes sense to cut a hole in somebody's skull to let those evil demons out, right? That's what you think causes it, right, determines how you want to fix it. If it's an imbalance of these humors in the bodies, well, then you got too much blood, you got a bloodlet, or too much bile or whatever. Brain congestion used to be this concept in the 1900s that people talk about as being a cause of psychological disorders, and very often one of the treatments that was well known was to spin people, particularly I think who were depressed. So the idea, if you really think that the problem is sort of congestion in the brain, well then spinning them makes sense, right? Or if you think there's some kind of neuron problem in the frontal lobe, then maybe you suggest surgery like a lobotomy to take out the frontal lobe. Right? So how you think things are caused determines how you want to treat them, right? But psychological conditions have these really complicated causes, and so people have tried lots of different approaches, and they've had different kinds of success. We'll talk focus more specifically on success of psychological therapy next time, but. So get out your clickers, just let me ask you a couple questions to set the stage for this. So, do you have a close friend or family member who's been admitted to a hospital or a mental health institution for treatment of a psychological problem? Have you ever known anybody, close friend or family member, who's been put into a mental institution or has been hospitalized for some psychological disorder? A, yes, B, no. So if you've known somebody who's been admitted to a hospital or been put in some kind of a mental institution, mental health institution's a better term. Okay. So about a third of you have, right? And most people, 67% of you haven't. Okay, so here's the next question. Do you have a close friend or a family member who's been prescribed drugs as treatment for a psychological problem? Do you know anybody, close family member or a friend who has been given drugs to treat some psychological problem, depression, anxiety, whatnot? Yes, or A, yes, B, no. Should include yourself in this, right? As you could in the other one, I suppose. So many more of you have had somebody that you know receive treatment, over 50% of you, so 56%, where only a third of you had known anybody that went into the hospital. And that really captures sort of the change in mental health treatment that's gone on in the last 40 to 50 years, right? There's been this move toward what's called deinstitutionalization. So starting the first way that you could think about treating mental illness, right, is with this biomedical model. There's some illness that you need that needs to be dealt with, with the sort of same ways that we treat physical illnesses, right? And as And this has been an extraordinarily effective mode of treatment, right? So, I mean, I've been talking about this long, particularly in terms of drugs, right? The use of drugs to address psychological disorders, to relieve symptoms, has been really remarkable, right? And there's been this huge change where in the past what you had was many people in a sort of this increasing trend of people that would be put into some kind of an institution, put away, particularly schizophrenics. People who have really severe mental illness tended to be placed in institutions, where with the advent of drugs, these drugs really had a lot of incredibly positive effects, particularly sort of the antipsychotic drugs that were given to schizophrenics to deal with those psychotic symptoms. That really started in the late 1960s, and it really coincides in a lot of ways with this rapid decline in the use of mental hospitals and to institutionalize people with mental health problems, right? The drugs were really, there was a couple of things going on. So first of all, the drugs were really effective, right? They were able to treat people. Then there was also sort of economic pressures, right? Economic pressures. It's expensive to keep people in institutions. There was a real sort of financial incentive to get people out of institutions, give them drugs, get them out on their own, right? And it also, the third part of this, is sort of coincided with the civil rights movement and this idea that sort of took hold that it was problematic to institutionalize people without their permission, right? So putting people into mental hospitals when they couldn't get out, right, by their own volition, well, that starts to be a problem. You wonder, well, where do you start drawing that line? When can you take away somebody's right to their own freedom? All those things coalesced in the early 1970s to create this sort of deinstitutionalization movement where people were, kind of released from these mental institutions and treated on the streets. You see that most or many of the homeless people that you see on the streets are the result of this kind of movement, right? Many of them are people with mental illness of some kind, sometimes under treatment with drugs, sometimes not complying completely with their drug treatments, but out on the street, and that's it's hard. Again, these severe mental illnesses, right, have this real debilitating effect on your ability to function, and so these people have trouble holding down jobs. They end up living kind of on the margins of society very often, right? So there's been a lot of effects. So drug treatments have been very effective in a lot of ways, right? But they've created or been associated at least with this problem of deinstitutionalization, which is good and bad, right? It's good to get people out. If you can treat them outside of institutions, right, that's much better, but it also has this kind of sort of side effect of homelessness, and many of the people, because drugs have to be taken, right? If you don't comply with your medication treatment, then you can end up in some really problematic situations. Many of these drugs have side effects as well that have to be dealt with. But it's been a mixed bag in some ways. I think in a lot of ways, biomedical treatments have been really terrific, right? But they have also associated with they have some unintended consequences and some side effects, right? And we've talked a fair amount about the drug treatments, right, and how they tend to change the activity of the neurochemicals in the brain. I want to talk about some other kind of examples, but other kinds of biomedical treatments. Again, historically, things like surgery, lobotomies used to be a fairly common treatment for depression and psychological and things like schizophrenia, where they just literally take out part or all of the frontal lobe of the brain, which leaves you not much left to function. So that's really gone by the wayside. But there are some fairly extreme biomedical treatments that are still used today, things like electroconvulsive shock therapy for depression, right? Which again is a really interesting one because, well, let me show you a little clip and then we'll talk about it afterwards. So here's a little clip that shows a depressed woman and her treatment with electroconvulsive shock therapy. Oops.
Electroconvulsive Therapy, or ECT, is a powerful way to treat severe depression, but it is used only when traditional medication approaches have failed.
Just look at me.
What about you look different?
Everything I smell.
You have a body odor?
My hair's falling out. I'm disgusting. I'm moving.
In fact, you think that you should be dead. Did you try to kill yourself? Did you really?
Yeah.
Tell me about it.
Took a bunch of pills, aspirin,
When was it?
on Thanksgiving.
When Mary attempted suicide, it opened all her feelings to the world. They now were expressed in all their intensity. She was worthless, hopeless, life was not worth living. She felt she was the devil, and she had the idea that the only way to end this terrible pain was suicide. She tried at home. Her husband brought her right to the hospital, and from that moment on, she had to be monitored. We had to have an individual sit with her 24 hours a day, because all she could think of was trying to kill herself. There were hours in the next few days that we had to put Mary into restraints. The alternative was that she would scream and try to kill herself by any device possible. It became necessary to treat her as rapidly and as effectively as we knew how, for this drive for suicide and this very severe feeling of unhappiness. At the beginning of ECT treatment, the patient is put to sleep, and 30 seconds later is given a dose of muscle relaxant.
The brother-toll's going in.
We find that
The lid reflex is gone.
up is up.
Bite block is in. Repeat it slow. Okay.
At that point, electric current is passed through the brain for a duration of half a second to 4 seconds. Typically, 6 to 10 treatments, spaced over 2 to 3 weeks, will be given. ECT produces a seizure, which needs to last for 25 to 120 seconds to be a good or effective treatment. After ECT treatments, patients will show confusion and loss of memory for recent experiences. Both of these problems clear up, and permanent memory problems after ECT are rare.
Mary, open your eyes. Treatment's all over with.
In Mary's case, medication did not help, and so electroconvulsive therapy was the best alternative. After treatment, Mary discussed her recent depression with her doctor.
The depression that I came here with, I don't really remember much about.
Remember nothing about it?
I do remember going home being in the hospital here and going home on Thanksgiving and taking a lot of aspirin. I remember that.
What happened on Thanksgiving?
I remember thinking I was the devil. And taking aspirin, and then my son coming from my neighbor's house and coming into the bedroom, and then I remember feeling bad that I had done that, because I didn't want to die and leave him. And when I told him to go tell his father that I had taken a bottle of aspirin.
Electroconvulsive therapy has a very important place in the treatment of certain depressions. It's not a panacea. It doesn't help everybody.
but it remains a very effective way for quickly reversing severe depression.
So that's a pretty good depiction of both somebody who's really, really severely depressed, right? I mean, you see her in the beginning, and she's profoundly depressed and suicidal, not responding to medications for various reasons, right? And which is when electroconvulsive therapy is used, when you're not responsive to symptoms, severe depression, you're hurting yourself, and it works. And it again, doesn't work for everybody, but and isn't for everybody, but works. And the other reason I like to show this is that we make fun of these older treatments, spinning, doing things. You look at this and you go, well, really? Does this seem sort of barbaric, right? I mean, coursing electricity through somebody's brain, right? But it seems to be effective in treating disorders. So it makes you think about, well, in the past people tried whatever they could, and a lot of it was sort of trial and error in some ways, and electroconvulsive therapy in many ways was developed in a very similar way. So a real extreme example of kind of a biomedical approach, right? Strapped down, treating people, and that's a very common, that biomedical model of using drugs, using various kinds of biologically based treatments is frequent and has been very helpful, but it's not the only kind of approach, right? There's a whole bunch of sort of approaches that are generally some kind of talking cures or non-medical sorts of psychotherapy. And you can define psychotherapy as some emotionally charged, confiding relationship between a trained healer and a sufferer, right? There's usually this, again, it has this quality of being a doctor-patient relationship where you're going in and getting treated by somebody who cares about you. 4 basic models. Again, when you look at the scope and the range of different psychotherapies, there are, again, hundreds and hundreds of different kinds of approaches. You can basically break them up into these 4 kinds: psychoanalytic or psychodynamic, also sometimes called interpersonal therapy, humanistic or existential therapy, behavioral therapy, cognitive therapy. And we're going to talk about all these in turn. And interestingly, in the sort of past, there was this sense in which people were very often steeped in a particular tradition and steeped in a theoretical position, like you were a Rogerian or you were a Freudian, right? Now, in sort of modern psychotherapy, the most common approach for therapists is what they call an eclectic approach. They sort of pick and choose from different kinds of psychotherapies depending on what seems to work best. So 50 to 66% of clinicians use techniques from multiple models. So they'll use behavioral therapy sometimes, cognitive therapy other times, et cetera. Those kinds of approaches, right? But underlying each of these approaches, there's a logic to them, right? So there's a cure, that a proposed cause of mental illness that then suggests a particular kind of cure. So if you were thinking about the psychoanalytic approach, right? So the basic idea of the psychoanalytic approach is, as we know, we talked about it, is that unconscious conflict rooted in childhood is really the cause of psychotherapy, that there's some kind of energy stuck back in the system from some conflict that you experienced during child rearing, either about toilet training or breastfeeding or masturbation, all those kind of, remember all these things that and psychic energy gets stuck in the past. Well, if that's the cause of psychological problems, well, what's the cure? Well, you got to figure out what that conflict is. You got to release that energy, and which will allow this person then to live, right? So if the problem is energy stuck in the past because of some conflict, then the cure is to figure that all out, right? And so psychoanalytic therapies are based on that idea. So in this case, and these are sort of the compare and contrast aspects of this, right? So therapists in psychoanalytic therapy is interpretive, directive, probing, right? So their whole goal, right, at first is really one of being a detective. I've got to figure out what that conflict is, right? So I need to probe. You're saying things in a way, and they use techniques, psychotherapists, psychoanalysts use techniques to try to identify that kind of conflict. We talked about things like free association. Again, you've got to get the superego distracted somehow so those id impulses will come up. So free association, dream interpretation. Things like analysis of resistance. We talked about, so this kind of probing idea. If you start to not, well, I don't want to, let's talk about your mother. I don't want to talk about your mother. Oh, so let's talk about your mother, right? So the fact that you're resisting that suggests that that's important. And then they use those kind of cues, right? The idea of transference, that very often the feelings that a person is feeling about somebody else will get transferred onto the therapist. So if they start to love the therapist or hate the therapist, right, they get a sense of, okay, now I'm starting to get you're transferring your feelings about something else onto me. What are those feelings? Like, all these things are cues, right, or clues to try and figure out what that conflict is. So you got to go through those things. Eventually, the goal is that the person and the therapist gains insight. So they go, you see this caricature. It's like, that moment when, it all's clear, what this conflict is that we uncovered. Once you realize that, then that's not enough, right? It's not enough to just identify that in psychotherapy. The next step is you've got to work through. You've got to figure out, okay, so that's where the conflict is. It's about me, my guilt about leaving my father when he was sick. And so what do we do? How do I think about that? Why does that bother me so much? And you work through that. And the idea is that eventually that will release that energy and you'll get over the conflict. So the drawbacks with psychoanalytic psychotherapy and with a lot of these psychotherapies is that it's a long, arduous, demanding process. So in classic psychoanalysis, you were in therapy for years very often, sometimes 3-4 times a week, right? For an hour, you go in and work on this for years because it takes a long time to identify the conflict, to work it through and all that sort of thing. It's very demanding. There is a version of it now that's called brief psychotherapy that, again, tries to use those same kind of principles. This basic idea about unconscious conflict that has to be identified and worked through, but they try to do it in a faster, more efficient, deliverable way. But if you're Freud, right, and you think this is the cause of psychological problems, this is the way you need to work through them, right? That's Freud's couch. Well, what about other kinds of approaches, right? What about the humanistic approach? Again, the humanistic approach, we talked about, Rogers being the chief proponent, has a different idea about the cause of psychological problems. According to Rogerian therapy, the cause of psychological problems is incongruence, right? This inability to accept the self as it is, and it stems from this experience of conditional positive regard as a child. So you have learned that you can really only love yourself when you do the right sorts of things, and love was withdrawn from you when you didn't, so you withdraw that love from yourself, so you have an inability to sort of accept yourself as it is. If that's right, the cause, well, then the cure is to help the person learn how to accept themselves, to have them be more congruent, to be more accepting of their own impulses and weaknesses, right, and to give them some kind of positive regard so that it allows them to grow towards self-actualization, right? So the idea is you've got to help them sort of accept themselves by giving them unconditional positive regard, guiding them through this process towards self-actualization. Right? So again, what it suggests is this kind of therapeutic talking approach, right? Again, it's a historical idea that somehow there's this problem back in the past and you've got to kind of deal with it. You've got to figure out why they won't accept themselves, help them accept themselves, etc. In this case, however, the therapist tends to be very non-directive and non-interpretive, right? This sort of, I always put up Stuart Smalley as being the example of kind of somebody, you're just being very positive, you're being very accepting. This is the therapist is sort of evasive, never really telling the the person what's wrong with them, not even referring them as a patient, referring them as a client, those sorts of things, trying to be accepting of them, trying to be non-directive so that they can learn to kind of discover themselves. The key therapeutic tools are called active listening, so listening to what the person says and kind of reinterpreting it, putting back in front of them. Being genuine yourself, so being open, revealing about how you feel. So you want the person to be genuine and accepting themselves. You kind of have to be genuine and authentic with them. Being empathetic, understanding how they feel, unconditional positive regard, right? This idea of giving people, being positive toward people so they can learn how to accept themselves. Again, the drawbacks of this kind of therapy are the same sort of thing. It's a talking therapy because they take this kind of historical approach. There's a problem way back in your past. We've got to work that through. We've got to identify it. We've got to talk about it. We're not giving drugs, right? We're talking to people, trying to provide them with what they need based on what the theory is about what causes it. Let me give you the best way to get a feeling for this is to give you a little example. These are clips. I'm going to show you a couple of them, clips from this famous older movie. This shows you Carl Rogers working with a patient. Her name is Gloria. It kind of picks up in the middle. I've seen these tapes lots of times. Gloria, just to give you a little bit of context, Gloria's essential problem seems to be that she likes to sleep around, right? And some of it sounds a little silly maybe on this, right? But that's the issue is that she seems to be ending up trying to get attention from men sexually in ways that she doesn't like. And this will show you, I'll just show you about a 5-minute clip of this and just Rogers working with her to give you a sense of what Rogerian treatment is like. So here's Carl Rogers and Gloria.
But I guess I heard you saying...
That's Carl Rogers.
Is it only the children? You don't like it as well when it really isn't.
I'm sure I know that's it, probably even more so than I'm aware of. But I only notice it so much when I pick it up in the children. Then I can also notice it in myself.
And somehow, sometimes you kind of feel like you're blaming them for the feelings you have. I mean, why should they cut you off from a normal sex life?
Well, a sex life, I could say, not normal, because there is something about me that says that's not very healthy to just go into sex because you feel physically attractive or something, or a physical need. So something about it tells me that's not quite right anyway.
So that you feel really that at times you are acting in ways that are not in accord with your own inner standards.
Right, right.
But you were also saying a minute ago that you feel you can't help that either.
I wish I could, that's it. And I can't. Now I feel like I can't control myself as well as I could have before for a specific reason. Now I can't. I just let go, and there's too many things I do wrong that I have to feel guilty for, and I sure don't like that. I want you very much to give me a direct answer, and I'm going to ask it, and I don't expect a direct answer, but I want to know, do you feel that, to me, the most important thing is to be open and honest? And if I can be open and honest with my children, do you feel that it could harm them if, for example, I could say to Penny, I felt bad lying to you, Penny, and I want to tell you the truth now. And if I tell her the truth, and she's shocked at me, and she's upset, that could bother her more. I mean, I want to get rid of my guilt, so that would help me, but I don't want to put them on her.
That's right.
Do you feel that could hurt her?
Concern. I guess, I'm sure this will sound evasive to you, but it seems to me that perhaps the person you're not being fully honest with is you.
So,
because I was very much struck by the fact that you were saying, if I feel all right about what I've done, whether it's going to bed with a man or what, if I really feel all right about it, then I don't have any concern about what I would tell Pam or my relationship with her.
right. All right. Now I hear what you're saying. Then all right, then I want to work on accepting me then. I want to work on feeling all right about it. Does that make sense? sense that that will come natural and then I won't have to worry about things. But when things do seem so wrong for me and I have an impulse to do them, how can I accept that?
What you'd like to do is to feel more accepting toward yourself when you do things that you feel are wrong. Is that right?
Right. And I feel like,
Sounds like a tough assignment, doesn't it?
yeah, I feel like you're going to say, now why do you think they're wrong? And I have mixed feelings there too. Through therapy, I'll say, no, look, I know this is natural. Women feel it. Sure, we don't talk about it a lot socially, but all women feel it, and it's very natural. I've had sex for the last 11 years. I'm, of course, going to want it, but I still think it's wrong unless you're really, truly in love with a man. And my body doesn't seem to agree. And so I don't know how to accept it.
Sounds like a triangle to me, doesn't it? You feel that I, or therapists in general, or other people say, it's all right, it's natural enough, go ahead. And I guess you feel your body sort of lines up on that side of the picture. But something in you says, but I don't like it that way, not unless it's really right.
Anyway, that's a good depiction of what Rogerian therapy in kind of classic form is like. You see, he kind of restates what she's saying all the time. He's working on getting her to sort of accept herself, or at least think about, well, gee, so the problem is that you're doing things that are wrong and you feel bad about it. And but he's very genuine, he's very open, he's kind of chuckling with her. He's not, he's sort of trying to be helpful, even sort of almost mocking himself. Oh yeah, so I'm sure this is going to sound evasive to you. Right? So that's kind of classic Rogerian therapy. And we'll come back and see her working with somebody else here in a minute. So any questions about that kind of idea? Again, very similar to psychoanalytic therapy in some ways, right? A real talking therapy, working on these old issues, but different in lots of ways too. One being very directive and pro, because they have different ideas about what causes the disorder. They have different ways that they go about wanting to treat it. The next approach I want to talk about is the cognitive approach. Right? These are somewhat more modern. These are the next two we're going to talk about, the cognitive and behavioral, are really sort of more characteristic of modern psychotherapy, much more targeted in a lot of ways. So the idea here behind the cognitive approach is this general notion that somehow the cause of your psychological problems is faulty thinking, dysfunctional thinking, that the problem is in the way you're thinking about things. Right, and so if that's if that's what's causing your dysfunctional feelings, dysfunctional behaviors, well, then the cure is to replace that old dysfunctional thinking with new functional thinking strategies. Right, so it's simple. If that's the problem isn't biochemistry. It's not conflict stuck in the past. It's not the lack of positive self-regard. It's just that you're thinking about things in the wrong way, and let's fix those. Right. So there's a whole host of these cognitively based kinds of techniques that, again, targeted in specific ways. Again, like the behavior approach we're going to talk about in a minute, it's really essentially ahistorical, right? So that there's a real sense in which they say, I don't care why you think this way. Let's just stop. Let's just change the way you're thinking, right? Let's not go spend, months, years trying to identify what in your childhood led you to be this way. Let's just sort of analyze the way you're thinking now and see if we can't give you some strategies to rearrange it. So therapists, again, because they're trying to say, Joe, you're thinking about things wrong, it tends to be directive and challenging very often, particularly this rational emotive therapy by Albert Ellis, and we're going to show him with Gloria here in a minute. Other examples, Aaron Beck in this, in depression, again, this has been one major approach besides, and again, depression is this interesting phenomenon, right? So a lot of it's treated with drugs and a lot of, that's been very effective. That's the most common form of treatment. Many people think, well, gee, that's really the wrong way to go about it. It's really just a thinking problem, this idea of stinking thinking, right, or a negative attributional style. And so, particularly with milder forms of depression, very often people will, or cognitive therapy will be used to try and change your attributions away from this kind of negative attributional style to a more positive one. Again, drawbacks is that these kinds of things tend not to work particularly well with really serious things like schizophrenia or really very severe depression or severe bipolar disorder, but they tend to work kind of most effectively with mild forms of depression, mild anxiety. That's Albert Ellis up in the corner, and this is kind of his ABC theory. Where, again, the idea is you have some, just to give you a broad outline, you have some activating event, and there's beliefs, and your beliefs can be both rational and irrational, and then they have consequences. So the idea is there's some event, how you decide how to think about it, which could be right or wrong, determines what you do, right? So if you think you failed A, B, when I fail, it just confirms that I'm a useless person who's never going to do anything good, and I'm just, and that determines what you do. Well, I'm not going to try anymore. Maybe I'll just lay in my room and be depressed. So the idea is you have to change, you have to dispute the wonky beliefs. That's what the term that Ellis uses. You got to somehow change the way they're thinking. If the consequences are bad and they're caused by the way you think about it, well, then you've got to change the way you think about it and give people some new ways to think about it, right? So there's a variety of these kinds of approaches, again, attributional therapies that are designed to change the way you make attributions. Here's a little brief clip of Ellis talking to the same woman, using this kind of directive, trying to change it. You'll see how different it is, how probing he is, and how challenging he is about the way she's thinking and about the assumptions underlying it, and saying, basically going after, gee, are you thinking about this rationally or not? And I'll just show a little clip of this. Again, same woman, same problem, different therapist, different therapeutic approach.
I feel what it is that I don't stand up to his expectations. I'm not quite enough for him. He's superior to me. Although I want this type of man, I'm afraid I don't have enough to attract him.
Well, that's the first part of the sentence, and that might be a true one, because maybe he could be superior to you in some ways. Maybe he wouldn't be attracted to you, but that would never upset you if you were only saying that. I think he may be superior to me. Now, you're adding a second sentence to that, which is, if this is so, that would be awful.
Well, not quite so extreme as that, because I've thought about that too. It's usually, I've missed my chance again, because when I want to become, if I want to show the very best of myself, because I think I have self-confidence and I have enough to offer.
Yeah.
But when I get afraid like that, then I show all the bad qualities. I'm flip, I'm so much on the defensive that I can't show my good qualities. And it's like, I missed my chance again. There was a good opportunity to be close to this man, and I loused it up again.
All right, but even let's suppose you're saying that, and I think you really are, but you must be saying something else too, because if you were just saying, hell, I missed my chance again, you'd say, all right, next time, I'll take advantage of what I learned this time and do it a little better. Now, you still must be saying, if you feel shame, embarrassment, shyness, that there's something pretty bad about your error in missing your chance again.
I don't know if this follows in context to what you're saying, but the thing I do feel is that I get suspicious then. Am I the type of woman that will only appeal to the ones that are not my type of guy anyway? Is there something wrong with me? Am I never going to find the kind of man I enjoy? I only seem to get the other ones.
All right, now you're getting closer to what I'm talking about, because you're really saying, if I am this type of woman that none of these good, eligible males are going to appeal to, then that would be awful. I'd never get what I want, and that would really be something frightful.
Plus, I don't like thinking of myself that way. I want to put myself on a higher standard. I don't like to think that I'm maybe just an average Jane Doe.
Well, let's just suppose for the sake of argument at the moment that that were so.
Right.
That you were an average Jane Doe. Now, would that be so terrible? It would be inconvenient. It would be unpleasant. You wouldn't want it. But would you get an emotion like shyness, embarrassment, shame out of just believing that maybe I'm going to end up like Jane Doe?
I don't know.
I don't think you could, because you still would have to be saying on some level, as I think you just said, and it would be very bad. It would be terrible. I would be in no goodness if I were just
Well,
Jane
I'd
Doe.
never get what I want. If I were just a Jane Doe, and if I'd have to accept it, I'd never get what I want, and I don't want to live the rest of my life with just icky men.
Well,
I
it's
want
not necessarily so that you'd never, you really mean your chances would be reduced, because we know some icky girls who get some splendid men, don't
Oh,
we?
that's
Yeah. You see, so you're generalizing there. You're saying it probably would be that I'd have a more difficult time, but then you're jumping to, therefore, I'd never get it all. You see the catastrophizing there that you jump to.
Yes, but it feels that way to me at the time. It seems like forever.
That's
All right, so see how differently he approaches. He's really challenging everything that she says, right? So he's going, oh, what do you, oh, that doesn't follow from that. What does that mean? You know, that you must be also assuming this. He's kind of, you know, you're generalizing. I love the way he gets in her face about things like, well, what happens if you were an average Joe? Maybe some of those men really are superior to you. Would that be so bad? You know, so he's talking to her in this very challenging way. You can see her thinking, trying to go through. And the whole logic there is that if you could just sort of dispute these irrational beliefs that people have developed, not caring really where they came from, right? Not delving into, oh, gee, there must be some deep, conflict with parents or something that causes her to think that way. Just saying, taking the beliefs as they are and trying to challenge them, change them. And the idea is that if you can replace them with better, more functional sorts of beliefs, then people will do better and stop having these emotional and behavioral issues. Any questions about that? You know, what you're seeing in these videos is really kind of the classic versions of these things. Classic Rogers, classic Ellis approach. The last approach I want to talk about, again, is another one that's really, really prominent in psychotherapy today, and that's this behavioral approach. And again, it starts with the same kind of logic. So what are the causes of psychological symptoms? Well, according to a behavioral approach, it's learning, right? So behavioral approaches are based on basic principles of learning, right? And that if you want to know why somebody is exhibiting some kind of dysfunctional behavior or emotions, it's because they learned to act that way. There's some faulty learning history that somehow they've either been reinforced to believe these things and to act that way, or they've been conditioned somehow through experiences to have certain fears or whatnot. And if you could just figure out, if you just assume that they're learned, right, you don't have to figure out how they were learned again, but if you assume that they were learned, well, how do you fix something that's learned? Well, you basically unlearn it, right? You try to get rid of those troublesome associations, somehow retrain people, have them relearn new and more functional kinds of behaviors. Again, it's an ahistorical approach. You don't really need to know or care where they came from, how they learned the dysfunctional behaviors. You just have to help them learn new ones, right? So these behavioral techniques tend to be unconcerned with specific causation. They tend to treat symptoms. There's two broad categories that I want to talk about that are really based on these two principles of learning. So one is the idea of classical conditioning or conditioning, and you can counter-condition things, that people have learned to have certain kinds of reactions to certain kinds of stimuli, and then you can simply counter-condition those. You can condition something after by pairing some undesirable behavior with either positive or negative stimuli to replace the previously conditioned response. So we're going to talk about that, how you can use both positive and negative stimuli to do that. And the second kind of behavioral approach we're going to talk about is the idea of using operant conditioning or reinforcement-based approaches, right? Where you set up some kind of a situation where you can reward desirable behavior and sometimes punish undesirable behavior, right? So one, it has to do with the idea of that people have established some kind of conditioned responses to things that need to be eradicated. The other one uses basic principles of learning to shape new behaviors. So let's talk about each of those and examples of them in turn. So the basic idea of counterconditioning, or the simplest version is just some kind of exposure-based conditioning where you get people to somehow pair. So the idea is that you've learned this response. So before therapy, classic examples of these behavioral therapies would be the use in something like a phobia. So the idea is that you've learned to have this phobia. Maybe you were bitten by a dog as a child, and so you're fearful of that dog. So the next time you see that dog, it's fearful. Every time you move away from it, it makes you feel better. So somehow you've developed this fearful response every time you see a dog. Right, so you have the phobic stimulus and fear. What essentially the basic approach of counterconditioning, right, is to pair, or exposure conditioning is to pair relaxation with the fear instead. Right, so somehow take this same stimulus and pair it with an incompatible emotional response with relaxation. And ideally that relaxation will then overcome the fear, so that the eventual goal of therapy, again, is that when you see that phobic stimulus, to not have that fear reaction, but to condition it to produce some kind of a relaxation or relaxed, calm response, right? It's a basic strategy. Really good example of a counterconditioning strategy is what's called systematic desensitization, right? And this is just exactly consistent with that sort of broader outline I just laid out. Right? The idea is to somehow get people to have a relaxation or relaxed response to the stimulus. So the systematic desensitization goes in a couple different steps. So the first thing they do is teach people these relaxation techniques. So you go through, you take the patient, you teach them how to kind of on command relax. And you go through a series of exercises where they get the person to say, okay, now I want you to just relax yourself, control your emotions, your arousal level. So you get people to be able to kind of do that on command, right? And you do that through training. They learn how to do that, right? The next thing they do is you set up what's called an anxiety hierarchy. So that you get people to essentially say, well, what are the things that you fear the most, and what are the things that you kind of fear the least about? So somebody comes in for something like, in this case, a snake phobia, right? And you say, well, what makes you the most anxious when you think about that? Well, being locked in a room with a big-ass snake, right? They go, okay, gotcha. What's a little bit less than that? Well, maybe being across the room from a big snake. Seeing a snake at the zoo through the glass. Being anywhere near like a worm or something like that. So you set up this thing where they have a set of things that make them anxious, but you can set them up from the lowest, the thing that makes you the least anxious to the thing that makes you the most anxious. So again, in this case, thinking about a string, a worm, handling a worm, thinking about a snake, handling a snake, actually handling a snake, whatnot, right? So then you get people, and then what you have people do is essentially go through the process of having them try to imagine a string and then put themselves into relaxation mode. So they practice that until they can do that. They can imagine a string and feel relaxed. Then they move up. Imagine a worm, right? Get yourself relaxed. Imagine handling a worm. As soon as they learn each of these steps, so eventually they move up the hierarchy so that they can even sort of slowly get to a point where they can handle a snake and still feel that kind of relaxation, right? So then at the end, the idea is that you can, go on and live a life without the fear of the snake. So it's a simple notion that you just try to pair relaxation with something that used to freak you out. So you take that positive stimulus, you condition a positive stimulus over what's something that's already, or you condition a positive reaction to a stimulus that used to produce a negative reaction. And this kind of, you systematically desensitize yourself. And the name associated with that is Wolpe. And again, very effective. It's been found very effective in treating things like phobias. There's also the sort of opposite approach, right? Where you simply try to extinguish a anxiety response by exposing people to the actual stimulus. And there's two sort of versions of this, implosive therapy or flooding. And the basic idea I have behind both of these is kind of you essentially just put people into the situation, right? You get them near a snake. And, so you sustained exposure to the anxiety-provoking stimuli, either real, so in vivo, so that you actually put them in a room with a snake, or have them imagine these things, some kind of, and you could even do that, with virtual reality kind of techniques, essentially until the anxiety extinguishes itself, right? So the idea is that if I train you to be afraid of something, right, I can teach you that every time I hold up my hand, right, that you're going to get shocked, right? And if I start holding up my hand, you'll start, after a while, every time I hold my hand, I shock you. As I hold up my hand, you'll all feel like you're being shocked. But then if I just keep doing that, holding up my hand, and then I stop shocking you, right? Eventually you're not going to feel those things anymore. You're just extinguished to it. And that's the logic. If the whole idea is that the system is trying to tie these two things together, right? Oh, that you're holding up your hand ties in with being shocked, but then if that stops being a signal, right, then people learn, oh yeah, that's not that anymore. So the whole idea is to simply expose people to things, either through sort of a gradual process of simply exposing without the relaxation, but just exposing, or sort of a flooding technique where you really kind of put them in the situation. This is, a spoof on it, right? Professor Gallagher and his controversial technique of simultaneously confronting the fear of heights, snakes in the dark, by putting people in this situation. Now it seems cruel, but that's, again, the essence of implosive therapy or flooding. Right? Again, pairing, in this case, you're simply just exposing people to the thing. There's another kind of conditioning-based response that's called aversive counterconditioning, again, that uses negative stimuli to do this. So this is the basic idea that you can kind of punish people out of things, right? You can associate something that used to bring pleasure with pain or discomfort, and people will eventually learn to dislike it. So these techniques are very often used for addictive habits, things like smoking or alcohol use. And again, the basic idea is you get something that has a natural response. So, the example here is using, I think, antabuse, or the best one to treat alcoholism. So you give people a drug that essentially makes them nauseous if they drink alcohol, right? Or I guess in this case, the drug simply makes you nauseous, right? So there's an unconditioned stimulus, the drug, that produces nausea. And then if you pair the drug with alcohol, you get nausea. So you simply train people to be nauseous whenever because of the drug, they're nauseous when they drink alcohol. It becomes associated with alcohol, and you decide that you don't like alcohol anymore. Same basic process that occurs when you go out one night with your friends and you drink 15 shots of tequila, and you decide that you really don't like tequila very much anymore, right? After you throw up the whole next day. I see smiling faces out there, right? So it's the same sort of thing, right? That taste then becomes aversive. And you could apply that reasoning in this systematic way to either do things like, have people associate, negative experiences with smoking or alcohol use or whatnot. And again, it's based on the same kind of learning principles. I don't care why you drink. I don't care, what kind of conflict caused you to drink. I'm just going to take you and stop you from drinking. I'm going to condition you to dislike drinking, right? So the use of these learning or behavioral-based principles. And again, these can be very, very effective. So one last clicker question. So what's the best way? Any people here have a dog? What's the best way to train your dog? So A, unconditional love. B, reward him for desirable behaviors. C, punish him for undesirable behaviors. Or D, both reward and punish him. So what do you think? If you're going to train your dog, what do you think you'd do? So reward and punish him, right? So you don't want to give him unconditional love. Come on, he's a puppy. No, you reward and punish him, right? So we know how to shape the behavior of animals, right? But those same processes, that same logic, that same, if you want to shape your dog's behavior into ways that are functional, right? You want him to go to the bathroom in certain places, you want him to, you know, heel along, not run out away in various ways, right? You can use these reward and punishment to shape their behavior. And that same process can be applied to human behavior. Right, and the reason through the use of these reinforcement-based techniques, and I bring that up on purpose, right? Because this is the sort of paradox of it, or the emotional paradox of it, right? That these things seem dehumanizing, right? To train, when I talk about it, training your dog, right? You go, oh, well, I don't want to treat people that way, or the way we train Shamu, right? And who's right, all the terrible things that we now know about the way they treat these large animals, but they can make them do amazing things, right? You don't want to treat people that way, but those same principles can be extraordinarily effective in treating people, particularly people with certain very severe kinds of conditions like autism and other things. But to use reinforcement-based principles, the use of reward and punishment, even though, again, it has this sort of has a tendency to feel sort of dehumanizing, right? But it can also be used very effectively. So again, you shape behavior. This is used in a whole bunch of different contexts. So in various kinds of institutions that people who still are seriously mentally ill enough to be in an institution or in various childhood institutions, they use things like token economies, right? So they set up a system where if you behave well, you get tokens that can be used to buy things that you want. If you don't behave well, you don't get those tokens. And what you find is when you set up those kind of token economies in an institutionalized setting, it improves behavior pretty dramatically, right? Because people will work to get things that they want, whether it's candy or cigarettes or whatnot, right? They will do things, and you can shape behavior in ways just like you can shape behavior with animals or anybody else. Things like modeling and vicarious reinforcement. So nicely, these kinds of things. What's impressive about humans, again, is that we can learn just by watching. And so by many these principles of modeling, of showing people, having other people be reinforced for things, can help people shape behavior. Now that works in token economies too. It's not just you getting reinforced. It's like, oh, that person did something good, they got something. Oh, that means that if I do that thing good, I can get that too, right? And so all those things really help and again, shape behavior. This has been used probably most, again, successfully and dramatically with autism. And this was really the brainchild of Ivar Lovaas, who you saw a little bit clip of. I think we showed that. Did we show a clip of him last time? Maybe not. Again, in the 1960s, he was the original person that said, gee, when you're faced with an autistic child, right, this is a really difficult situation to be in. This child is hurting themselves very often. They are not responsive. They won't focus. Their language development is poor, so they're not understanding things. So how do you deal with a child like that, right? And how do you can't have a talking therapy with a child like that. And so what Lovaas' idea was, again, to use these behavioral principles to shape their behavior, right? And he was, originally in particular used both reinforcement, reward, and punishment. Right, it really was hard. It's hard to find video of it anymore, but in the original work that he did, it was very controversial because it has this dehumanizing flavor to it. He literally used a cattle prod on kids. So when the kids would hit themselves, he would shock them, right? And he found that they would stop hitting themselves if you shocked them. That for whatever it was, that kind of punishment stopped the behavior. Now you can see that's a little extreme. And in fact, what you find is when, it was really interesting, a few years ago we had one of the lead animal trainers for SeaWorld, this was maybe 15 years ago, I saw it, come in and talk about how they train those animals, right? And you know they almost never use, at least that's what they say, never use negative reinforcement on those animals. The way to work with animals is to use positive reinforcement, because negative reinforcement tells you what not to do, right? Or punishment tells you what not to do. It's really punishment, not negative reinforcement. But punishment tells you what not to do, but it doesn't tell you what to do, right? So it's much better to use reinforcement-based techniques, reward-based techniques to shape behavior, right? And you could do that, and it's this relatively slow process where you, as soon as somebody does anything, the patient does anything that resembles the desired behavior, they get reinforced, right? When you get reinforced, you're more likely to do that behavior again, and then as they get closer and closer, you slowly shape the animal's behavior, or in this case, the child's behavior, right, to approximate the kind of desired behavior you want. So again, it doesn't always have to become in fully formed shape. If you want the child to pay attention, you know, if they just kind of look towards you a little bit, you won't reinforce them. And then after a while, you get them so that they'll only reinforce when they're looking right in your eyes. Then you can shape people and take behaviors, just like with you know, the whales. They go out, and if they go out in the right way, well, then they reinforce. Well, they go out in the right way and they jump. Well, they reinforce that after a while. And after a while, you get them to jump, and they only get it if they flip. And you can take these really complicated behaviors that you see Shamu do, right, all the different things that the whale does, and does that all built up in these pieces by simply shaping the behavior. And let me show you just a little example of this kind of, it's called applied behavioral analysis. And here's just a real brief clip of a young woman working with an autistic child doing this kind of shaping. So she's helping him out, and then so that doesn't demonstrate it, you know, as well. You have to imagine this child's had a whole history of this, right, where they build up to this kind of reinforcement, where, you know, where every time the child you know, approximates the behavior of focusing, of doing the things, and it gets rewarded and eventually shaped to do those sorts of things. And again, this has been a really dramatic advance in the treatment of autism. It's had hugely positive effects, but you can see how it has a little bit of a flavor of kind of manipulation, that you're taking and manipulating somebody. I was going to show you a clip. I don't know how many people watch The Big Bang Theory. There's a great series of clips where Sheldon sits and reinforces Penny and shapes her behavior by giving her chocolates, right? It's the same thing exactly, and you can just take behaviors and build them up, right? And in that case, the idea is it seems really manipulative to do that to people. That's the kind of thing we do to animals, right? But it has these incredibly positive effects on these children's outcomes, and teaching them how to orient toward people, teaching them how to behave in much more functional ways, right? So that's the idea of behavioral therapy, right? Very targeted. So you've got these very different approaches. You can treat things with drugs, treat things with other kinds of biomedical approaches like electroconvulsive therapy, different kinds of talking therapies which care deeply about the past, or very targeted ones, right, where they just don't really care kind of how you got that way, but we can treat the symptoms. All of these are in the sort of bag of tricks of psychologists these days, and they use them in different situations, and we're learning a lot more about what works well with what. Any questions about any of that? What I want to talk about next time, the last time, is talk about how well does all this work? What's the evidence about whether psychotherapy of any kind really works, and what don't we know yet? And so make sure to bring your papers if you got them on Thursday for our last class. We will see you then.